So the first thing I wanted to talk about is the actual reality on the ground, which people have said already, which is everything is harder here, right? And for some of the people in diaspora, you sort of get the sense, everybody says, yeah, I know everything is harder here, but you really don't understand until you have actually been in here. There was something that an institutional investor told me that I've been kind of spouting a lot, and they said that, do you know that it cost 3 times as much, up to 3 times as much to build a hospital in Nigeria than anywhere else on the continent. And the reasons that they gave were, all the reasons that we know. We have issues with skills gaps. There are tax and regulatory problems. Our utilities issues with access to power, rent seeking, aka corruption, from the top to the very bottom, 3 times the amount. And what I realized after being here, it took me a while, but I think what I realized was that a lot of these things are as a result of like a series of actions and decisions that started before some of us were even born in this room. And what that created was, and what it has created, is an environment in which the vast majority of Nigerians' priority is safety and survival, right? Which is very different from where diasporans are coming from, where your safety and survival are not a priority. They're there. And your priority is, you want to give back, you want to develop yourself, you're looking at things for growth. And so if you don't understand why things are the way that they are, you will get frustrated and it may make you quit. But I think it's very important that we understand what those things are. So for me, I'll take the issue of capacity, so clinical skills, for example. So one of the things that I found after a couple of years was that, this issue of bad practice in the medical profession. And I actually was able to kind of narrow things down. I noticed this pattern where doctors, so I deal with lots of different healthcare professionals, but mostly doctors. And some of the doctors who have been out of medical school, let's say 7, 10 years on, who have not been able to get a place in a training program. That was where I saw the largest concentration of really, really bad practices. And what I've grown to understand is that, they too also started trying to improve themselves and, give back to the community and do things for the patients. But they've been so disillusioned with the system over time that their priorities have switched. And their priorities are simply about the security and safety of themselves and their families. And it leads to all sorts of things that are, beyond, clinical practice that they do. But it's important to understand that. And understanding that has helped me to navigate this particular issue of skills gap. And it's helped me to understand that if you are going to come back, then you have to take on the role to help within that situation. So so whatever it is that you do, whatever specialty that you're in, whether you're a physician, you're a nurse, you're a physiotherapist, etc., you're also going to be a trainer, right? So you also have to be able to impart skills. You also have to understand where people are coming from. Otherwise, you will be frustrated. It's easy to sit back and just complain about everything. But once you sort of understand that, then you can start to make a bit of a difference. So I say all this just to say that, things are hard, but they're hard for everybody. They're not just hard for you that are coming down. Things are harder for everyone. The next slide is supposed to say that there are no medals for suffering. And The reason I say this is because I have suffered. And I have no medals. What I have is 10 pounds of weight loss and a couple of other things. So I read somewhere that we need to set goals that match the scale of our challenges. And one of the mistakes that I made was that we set goals to fix all of Nigeria's healthcare challenges, right? So when we start, and that's really a role for policymakers, people like Olumide with huge amounts of money, the ministries of health. So when we started, we tried to do quality accreditation across several facilities. We were trying to do improvement across 120 people in like 7 different places. We started a training program for junior doctors to improve their skills. And then all of this at the same time, we're getting extorted by the area boys while we're trying to fix the building that is going to provide the care for them and their families, right? And I think, so like I said, so that didn't really work out. Like there was a lot of suffering that was involved there. So at some point, we actually changed track and we said, okay, look, let's keep these interventions small, but let's be very, very direct. And let's ask a couple of questions. First of all, who are these people that we say that we want to treat? What do they want? What do they need? Can we get one place sorted out with accreditation to this particular level? Can we improve one service and monitor the indicators that come with that and learn from it and do something else? And surprise, surprise, when we did this, we learned that this is a much better way to get things done. We focused on those few interventions that were within our range of expertise and skills, and not only did we learn faster, but we were also able to kind of build the morale of people who had been slugging away trying to actually do things. It can be very, very demoralizing if you're dealing with all the hardship and then you're also not seeing any momentum in what it is that you're doing. It is something that I think has broken a lot of people. There are so many people who have come and they've gone and they swear they will never come back. But I put it to you that some of this also has to do with changing your own mindset and your approach when you're actually coming into this environment. So in terms of what we did, we learned a lot of stuff. We learned the stuff about our patients. I'll talk about that a little bit later. We were able to improve quality. We surpassed our accreditation target at that particular location. We were able to use technology and get a lot of traction in lots of different areas that we were then able to build on. The other important thing was that we spent a fraction of what we had spent so far. Somebody had mentioned here about the alignment of the head, heart, and pocket. And I think what I want to say is, in this environment, it's very easy to spend a lot of money with nothing to show for it, right? Like, if anybody had told me that I could spend the amount of money that I spent and not have a thing to show for it at the end of that period, I would never have believed that in my entire life. So I think that's just something that people need to think about. The other thing that I learned from this process is that there's a difference between running a business and trying to improve a process or create an innovation. They're two very different things, right? Trying to improve a process and create an innovation requires you to be open to experimentation. You will learn a lot. You may not necessarily make money while you're doing that. You may eventually, but the financial part of it is not necessarily your goal, right? The things that you learn from there can become invaluable in the running of the business part. So that's another thing to just kind of bear in mind. So the next slide I said here, humble yourself. One of the worst things that I think that you can do if you're coming from the diaspora is to, and this is doctor, nurse, whatever, is to make assumptions about the state of affairs here. It doesn't mean that some of your assumptions are wrong, but it is much better for you to come in here with a searching and questioning attitude than a point and fix one, right? It will save you a lot of headache as you go. So one example, it's a bit roundabout in terms of assumptions, was when we came, we made this assumption, which is again based on stuff that even people were saying here, that Nigerian patients want a one-stop shop. And this is in the context of a dense urban area like Lagos. So that's what I'm talking about. Nigerian patients want a one-stop shop for their healthcare, and this explains why we have so many primary care centers that try to do everything, that they take on these patients that have very high risks of complications, even though they know that they don't have the right resources and equipment to actually sort these issues out, right? So one of the things that I saw that kind of flipped the switch was I saw a man with end-stage cardiac failure. I'm assuming that there's enough medical people here, but end-stage cardiac failure in swollen legs, you can't hear his heart because there's fluid everywhere, his veins are swollen, he can barely talk because he's short of breath. And where was this guy? This guy was in a primary healthcare center bed that had no monitoring, no intervention, nothing, and he was waiting for the cardiologist to come in 5 hours to do an assessment. He died, right? Like, that's just how that story ends. That guy died. And so we decided to say, look, we need to question some of these assumptions. And so what we did was we did an experiment, and we basically shut down secondary care inpatient services in one location. And we created a link with another secondary care facility that had resources, that had personnel, that had the right equipment that was there. We sorted what we could do, and then we sent what we couldn't do out. And what we saw almost over a period of like six to 9 months, was a dramatic reduction in any adverse events at all, because we followed up with what was happening with these patients once we sent them there. No mortalities whatsoever, because we were able to catch things early and send them where they need to go as soon as possible. So for us, that was something that we wouldn't have known if we didn't question certain assumptions around how care was given. There's just one point, Douglas, that I think I disagree with you on, which is this issue of incentives for referrals. I know that it's a slightly different world within different specialties, but from a primary care perspective, once you introduce incentives for referrals, what you see, and this has been studied, this is everywhere, and I've seen it live. The minute you introduce incentives for referrals, what you get is a spike in your referral rate. And then once you look at those referrals, you find out that a significant portion of them were inappropriate, right? And then you now have this issue of adding an additional process to whatever your quality improvement process is to now start checking what's going on with referrals, checking your data. Do you see a spike in referrals going to this Alimosho hospital from so-and-so doctor from your particular place? And then you now have to, you introduce another level of complexity that is not necessary and that doesn't necessarily serve the patient's interest. But that's from a primary care perspective. I understand that it might be slightly different when it comes to specialties. The other thing is we wouldn't have been able to validate any of this if we weren't able to collaborate, right? So if we weren't able to create this linkage with the secondary care provider, which was not under our control in any way, we would not have been able to validate any of this because we wouldn't have been able to get the information to find out what's going on with these patients. So collaboration is important here. I think, so in terms of my learning and what I would say with collaboration is you may start off doing something on your own just so that you can get the traction. But because healthcare is an ecosystem, there is no way that we're going to be able to create anything that is sustainable without integrating with the other aspects of the healthcare value chain. It's just not possible. So I've had my fair share of failed collaborations, everything from, whether it's starting business, partnering with clinical services, trying to do partnerships with health insurance, Yeah, just all sorts, let's just put it that way. But for me, I think what those have become are more learning points about how and when to actually collaborate, as opposed to putting you off completely about collaboration. So it's just the point that like you can't escape it, but it's something that there's enough people who have learned from it on the ground that if you ask enough questions, you shouldn't have to stumble the way that some of us have. And also, I think my experience has been that like minds will seek each other out, right? Like the people in this room, like how many, if I suspect that not too many people would get up on a Thursday and come to a healthcare conference to stay here till 5 o'clock in the evening if they were not interested in doing things better in some way. So right here, in terms of collaboration, this is probably where it should start. The next slide says putting people first. And this was really around trying to remember who we're doing all of this for. It's like through all the hardships, I think sometimes it can be quite difficult to remember like why we're actually doing this. Like I love when Douglas said, you know, Nigerian patients are worth it. That's his thing. He's been saying that for years. And it's really quite true. Sometimes it gets lost in moaning, it gets lost in the PowerPoint presentations about, you know, the statistics on what's going on with maternal mortality, et cetera. You know, sometimes those certain words, we've heard them so many times. We hear maternal mortality, we hear, you know, this, and then we just get lost. There's a doctor, Dr. Efumbo. I love the way when she talks about maternal mortality, and she's trying to talk to you about the numbers. Because I'll admit that I've been to so many conferences that when they say the numbers, I'm just numb to it. Like my brain is just switched off. Dr. Efumbo comes on and she says, this is how many mothers die every year in Nigeria. And let me tell you what it means. It means that a jumbo jet full of women and children crashes every week for the entire year. That's what it means. So she says something like that, completely changes your reality. So things like, you know, like I can sit here and I can say that there's a discrepancy between the outcomes of low-income patients in rural areas versus high-density areas in Nigeria. And it's like, okay, that's fine. But what does that mean for Ladipo market in Mushin, right? And one of the things that I realized on this journey is that we have no idea what patients want because we don't ask them. Like we don't ask them any questions. So we went out and we started asking questions. So we asked hundreds of people in Ladipo market. We brought them in and we sat with them and we said, you know, who are you? What do you do? Like we collected a lot of information from these guys. How do you seek healthcare? What are your challenges in the public sector and the private sector? All this other stuff. The information that we got validated some assumptions and data that everybody already knows. And some of it just gave us more insights to be able to adjust what we were doing to them. So for example, we validated the fact that more than 70% of the people in that area were informal sector, so they work for themselves. And what we found was that time was a significant factor in how they make their decisions on where to seek healthcare. In some cases, almost the same as cost, because we're talking about primary healthcare in rural areas, which is already cheap, right? Like you can see a doctor for 1,000 naira. So they're not quibbling about those things. And then based on that, we now said, okay, well, let's look at waiting times. What do waiting times look like? And waiting times on average for busy sort of private, so this is private sector, so not public sector where you wait all day. They already told us that. They don't like going because they wait all day. But even in the private sector, if you have a headache, you have a fever, you can wait there for an hour and a half at best, you know, maybe 2 hours before you see someone. So we tweaked our processes a little bit. We did some stuff with task shifting and working with nurses, and we brought that down to 25 minutes. And lo and behold, we saw loads more people coming in, and they were much, much happier with things. The reason I'm saying this is that I think sometimes some of us can be so focused on delivering superior quality service that tunnel vision leads you to now create something that, yes, it may be a fantastic service offering, but it has no bearing on the needs of the people that you're trying to actually serve. I think Dr. Coca last night actually was talking about this. So this thing that I've described, where you have an outpatient center that works very, very well, it has links to secondary care, it's got technology, it can do diabetes management, hypertension management. You take that same thing out of Lagos and you go plop it in a rural area in Erua, and it's useless, right? Because what they need is completely different. And so I think this is also part of this whole thing when you're coming here, and this is a discussion we also had yesterday, you almost have to be like a public health person. So you still have to do your needs assessment. That's your public health thing. But get to understand who the people are that you're trying to serve and whether or not what you're trying to do can actually make a difference for them. I think, I think the main learning here for me was that we have to be in tune with patient preferences as they describe it to you and not make assumptions about what it is that they need. Otherwise, there will always be a mismatch between what you're doing and what the patient actually wants. So, I could go on for a while in terms of things that I've learned, but I think I just wanted to wrap it up with a summary of some of all these things for people who are maybe thinking about coming back or who have just come back. And the first thing is, come with an open mind. Take the time to find out what's happening on the ground. There is a lot happening on the ground across all parts of the healthcare value chain. There's an incredible amount of innovation taking place in the country right now. I think we should explore the unknowns as if we were children in a way. So you have to start asking those very basic questions that you may have taken for granted wherever it was that you were practicing, right? From that question of like, who is the patient and what do they want? Don't make any assumptions about any of those things. And I think you'll be able to go a lot further with that. The other thing that I will say is try something first and make it manageable. We came in, we went big, and we almost crashed out. And then only when we went small were we able to kind of get the kind of results that gave us enough confidence to move forward. If you haven't practiced in Nigeria ever, or you haven't practiced in Nigeria for a while, then I wouldn't recommend that your first move to Nigeria is building a hospital in your village, right? Like you're setting yourself up for a lot of potentially unnecessary headaches. If you start small, you will learn certain things, even if they don't work out the way that you initially intended. In fact, when it doesn't work out the way that you initially intended, you will learn a lot that will inform whatever it is that you want to do on a much larger scale going forward. And then another thing is don't be discouraged by rejection from your colleagues that are on the ground. Their reality is different from yours, and it's important that you know it, but that you also respect it. There are lots of like-minded people who are already here doing interesting things, and you can always work with them. And I think the results of the work that you do will speak for itself and convert those who need to be converted. Partnerships, I think, as I mentioned, is always important. My personal perspective is that it doesn't need to happen from day one if it's something that can allow you, if you can move quicker without it, but you will have to do that in the long run. And then, finally, it really is about the patient. Like, always remember that it is about the patients. Like most people that come back, most people who got into medicine, it's really about how do we make a difference for human beings who could be your nephew, your sister, and that's how we have to really look at this. So that's me for the end. Thank you very much.